Today I am going to talk of a disease which is very common in Indian population because of the fact that Indian diet, Indian habits, Indian genes are different from the other populations in the world. So we are facing a common disease, rather havoc of a common disease, that is coronary artery disease. And this coronary artery disease occurs because of the fact that there is a accumulation of atherosclerotic plaques or atheromatous plaques in the major epicardial coronary arteries, giving rise to significant obstruction and thus produces angina on effort, angina at rest, which is called unstable angina, or there may be acute complications like rupture or formation of a thrombus in the atheromatous plaque in the proximal coronary arteries, giving rise to acute total occlusion of the coronary artery, giving rise to acute myocardial infarction, which is very fatal in most of the times. But if you treat it properly with a proper treatment like thrombolytic therapy and primary PCI, most of the patients can be saved by this sort of treatment. Now, why this atherosclerotic coronary artery disease occurs in Indian population? There we have to look for so many factors which are responsible for that. And we know that the Indians' customs, Indians' dietary habits, Indian basics, Indian genetics are different from the other populations. We are taking much more salty food, we are taking much more fatty food, we are taking less vegetables, salads and fruits, and thus we are much more accustomed to have diabetes mellitus, hypertension, and sequelae to that is coronary artery disease. And another important factor for the Indian people who are having this atherosclerotic coronary artery disease is because of the fact that they are having dyslipidemia. There is increased incidence of dyslipidemia in Indian population, and dyslipidemia is one of the important factors for having coronary artery disease in Indian subjects. Now, what is dyslipidemia? Dyslipidemia means there is abnormal lipids in our body, in our circulation. And what are the dyslipidemia common types? Increased cholesterol or hypercholesterolemia, increased triglyceride or hypertriglyceridemia, or there may be low HDL and increased HDL, and they are all together consisting of dyslipidemia. Now, Indian dyslipidemia is different from the dyslipidemia which occurs in the West. In West, we know that there is a hypercholesterolemia, increased LDL, but in Indian population or Indian population subsets, there is a normal cholesterol or maybe slightly higher level of cholesterol, but there is a increased triglyceride, low HDL and increased LDL, and also there is increased lipoprotein. And combined together, this high HDL, low HDL, high LDL, increased triglyceride and increased lipoprotein, they combine together give rise to what is called Indian dyslipidemia. Now, this Indian dyslipidemia is one of the important predisposing factors for increased incidence of atherosclerotic coronary artery disease. Now, how we are going to take care of this dyslipidemia, and as a result, it will prevent this increased incidence or increased rate of coronary artery disease. Now, dyslipidemia, most of the times either it is genetic, meaning genetically we are susceptible to have this type of dyslipidemia, or due to the abnormal diets and lack of exercise and increased rate of smoking. So these are the four factors which give rise to this increased incidence of dyslipidemia in Indian population. Now, genetics, that part we cannot rather correct, but what are the abnormal food habits you can correct? Low saturated food, low saturated fat, then low content of fat, increased rough or what is called coarse cereals, giving rise to increased carbohydrates, and there is a less salt, and these are the types of diet. If we practice in our day-to-day life, then of course definitely it will try to reduce this abnormal dyslipidemia in Indian population. Then important factor is that if you do regular exercise for at least for half an hour, brisk walking or swimming or some jogging or some yoga, that also reduces this abnormal dyslipidemia in Indian population. So you have to increase your physical activities, you have to walk, you have to increase your day-to-day physical activities during your daily life, and that will also give you the extra mileage for correcting this dyslipidemia other than the diets. And of course, smoking is also causes low HDL and increased LDL. So if you stop smoking, also that will also try to correct this abnormal dyslipidemia in Indian population. Now, let us come to that exact point of this dyslipidemia. I told you the abnormal dyslipidemia in Indian population is this slightly increased cholesterol, high triglyceride, low HDL and increased LDL. Now, how you are going to treat this sort of dyslipidemia in our patient so that the patient either as a primary prevention, so that patient will have less chance of developing coronary artery disease, or if already they are having coronary artery disease, we can prevent the catastrophe of acute myocardial infarction, ischemic cardiomyopathy, unstable angina if you give proper statin therapy to all these patients. Now, what are the statins that are available to us? That is atorvastatin, rosuvastatin, pitavastatin, simvastatin. These are the different statins which are available to us for our day-to-day treatment. And amongst these statins, the commonest statins which are accustomed to use and which are very much effective, that is one is atorvastatin and another is rosuvastatin. And if you ask me which statin is better or which statin is much more effective amongst these two, but I will say that both are effective, both are quite potent if you use it properly in a judicious way. Now, when you are going to use the statin, there are 2 or 3 types of statin mode of therapy. What is called high intensity statin therapy, medium intensity statin therapy, and low intensity statin therapy. Now, low intensity statin therapy, that means 10 mg atorvastatin or 5 mg rosuvastatin, we are giving it only as a prophylaxis, means for primary prevention. But for secondary prevention, that means the patient already had a heart attack or primary angioplasty or ischemic cardiomyopathy or ischemic heart failure. In those sort of situations, we have to give moderate intensity or high intensity statin therapy. Particularly, high intensity statin therapy is effective after acute myocardial infarction or after unstable angina or after primary PCI. Now, high intensity statin therapy consisting of, if you give atorvastatin, that is about 40 to 80 mg per day, or if it is a rosuvastatin, that is about 20 to 40 mg per day. This is high intensity statin therapy. Now, if you consider the medium intensity statin therapy, I mean in some situations, if you give medium intensity statin therapy where there is a effective lowering of LDL cholesterol level, that means the optimum LDL cholesterol level should be less than 50% of the previous level, or the absolute level of LDL cholesterol should be less than 70 mg per deciliter in patients who are having already established coronary artery disease, or as a primary prevention, you have to keep it down to less than 100 mg per deciliter of LDL. And whether medium intensity statin therapy or high intensity statin therapy, it all depends upon the degree of reduction of LDL cholesterol to an optimum level, and the optimum level what we have discussed just now, or if there is also, in addition to this optimum level of LDL, there is what is called pleiotropic effects of these statins. Now, what do you mean by pleiotropic effects? When other than this reduction of cholesterol level to an effective way, there are other some beneficiary effects of medium intensity or high intensity statin in patients who are having already coronary artery disease, and this is called pleiotropic effects. Now, when we are considering the reduction of cholesterol level by these statins, we know that these statins causes blockage of the HMG-CoA reductase enzyme, and because of the blockage of the HMG-CoA reductase enzyme, which is one of the principal key enzyme or leading enzyme for synthesis of cholesterol from the basic substance of acetyl-CoA. Now, when the HMG-CoA reductase enzyme is blocked by statins, there is a reduction in the cholesterol synthesis, and thus there is a total cholesterol level comes down, and as a result LDL level comes down, HDL level goes high, triglyceride also comes down little bit. Now, what do you mean by this pleiotropic effect? Other than this lowering of cholesterol, pleiotropic effects means these statins also has got some effects, like it has got an anti-aggregatory platelet effect on the platelets, causing anti-aggregation, platelet aggregation effect, and as a less chance of thrombosis, and also it causes stabilization of the unstable atheromatous plaques by producing some inflammatory mediatory substances like blocking of the matrix metalloproteinases, and it also prevents the oxidation of the LDL cholesterol, and also it causes less recruitment of smooth muscle cell from the middle wall into the endothelium, or blockage of the or activation of the what is called mast cells and other cells, which causes emission of the different types of secretory molecules, and as a result aggravates the atherosclerotic process. So this process can be blocked by this high dose or medium dose of statins, and as a result they causes stabilization of the atheromatous plaques, and thus they have got a salutary effects on the management of atherosclerotic cardiovascular disease. So we can see that these statins, in addition to the reduction of cholesterol level or LDL cholesterol level, it has got some effect on the atheromatous plaques regression and what is called pleiotropic effects, and also it has got a effect on the platelets, causes less platelet aggregation, less platelet activation, there is a less chance of thrombus formation, less chance of myocardial infarction. So statin use should be routine in all patients, whether it is as a primary prevention or as a secondary prevention. In primary prevention, should be a low dose of statin. I told you 10 milligram atorvastatin or 5 milligram rosuvastatin. And when we are going to use these statins as a primary prevention, and what is my advice, that if the patient is having some high risk factors for developing coronary artery disease, like patient is diabetic, patient is obese, he is a smoker, but not yet having coronary artery disease, so those are called high risk patients who are going to develop this coronary artery disease. In those sort of situations, statin gives as a primary prevention therapy. But already patient who has developed this coronary artery disease, we have to give medium intensity or high intensity statin therapy to prevent further progression of atheromatous plaque, and thus prevents further mortality in coronary artery disease. Doctors, ladies and gentlemen, what I will advise, that in a present day situation, if you want to prevent atherosclerotic coronary artery disease in Indian population, you have to give statin as a primary prevention or as a secondary prevention. Now you have to consider whether we are going to give low dose statins or medium dose statins or high intensity statins, depending upon the situations what I have just now described. And I think this is going to give great relief to this increased incidence of coronary artery disease in Indian population.